Okay, thank you so much.
All right, so should we start? Great. Thanks everyone for joining. I think this is actually the first time I'm doing it like this. So it's going to be a new experience. I hope I don't mess it up too much. I guess I'll keep the chat box open so I can see questions as they roll in. Does that make sense? And let me get started with the PowerPoint and we'll go from there. Let me share the screen first, I guess. Oh, that's good. And share. All right, you should be able to see the screen, my screen now. And all right, can everyone see the PowerPoint okay? Fantastic. All right, so yeah, I was asked to give a talk on tummy troubles is the title we used, and it's a kind of a wide term, right? It can be used for a lot of different things. In specific, we decided we were going to talk about irritable bowel syndrome. So let's get right to it. Irritable bowel syndrome is in and of itself is not really one entity. In the GI world, it's such a diverse, wide-ranging field in the sense that you can have two patients with the same disease have completely separate symptoms and vice versa. You can have two patients with completely different diseases who present with the exact same symptoms. So it's always good to, when you're talking about the GI world, to try to hone it down to one specific topic. So irritable bowel syndrome, within this, there's a lot of different subtypes of it, and we're going to talk about what are the different subtypes that we recognize and why some of the rationale behind it. And then we'll go over a brief overview of what might be causing it, and then the subsequent treatments that are currently available or utilized for it. So to begin, why is it important to even talk about irritable bowel syndrome? I'm sure most of us have some experience with it or have been exposed to it. It is the most common problem any GI doctor will deal with. It takes about, an estimate's about 10 to 20% of the general population experience symptoms in keeping with it. And I think what's important is actually the last line there. It is the second most common reason why people miss work. And now, of course, you can always extrapolate beyond work just to life events, right? So it's something that's there. I think we don't talk about it as much as we should, or we don't spend as much time talking about it as we should. So what is it? It's a set of symptoms that, with the hallmark symptom, of course, being abdominal pain. There's also changes in bowel habits, whether it be diarrhea, constipation, or both. And it's generally chronic in nature. The pain itself can be widely variable. As I mentioned before, there'll be some people who talk about pain in the upper abdomen, lower abdomen, right, left side. It really doesn't matter. It can be sharp, it can be crampy, it can be always present, or it comes and goes, or episodic. It almost always does get worse at times of emotional stress. And it also, one of the interesting things that it does seem to center around bowel habits, meaning that patients who will often describe that their pain improves with a bowel movement. Sometimes it can even be caused by having bowel movement. There is associated symptoms of bloating and increased passage of gas as well. If I'm going too fast or I go by something, oh, sorry, I hit the wrong button. Go by something, just please send me a message or let me know. So, all right. So how do you make the diagnosis of irritable bowel syndrome? There really is no test to diagnosis. This is something you use a set of criteria, you see what matches up best, and you kind of make it a diagnosis based on this. I like to tell my patients that really this is a diagnosis of exclusion. So you exclude all the other potential confounders, and what's left then is irritable bowel syndrome. But we do have a more elegant system of diagnosis, something called the Rome 4 criteria. For anybody who's been reading on it, you'll see there's a lot of other criteria out there. Something called the Manning criteria is also widely used. In the United States, we really stick to this Rome 4 criteria. When I started my training, it was Rome 3, so it moves along as time progresses. But basically, it's recurrent abdominal pain at least 1 day per week over the last 3 months. It's usually associated with at least 2 or more of the following: related to defecation, as I mentioned, associated with a change in stool frequency, either too much or too little, and associated with a change in stool form. like the appearance of the stool. So sorry about that. So what does that mean, the stool frequency and stool form? There's this stool chart, so to speak, and patients really love it. For me, I don't think you really need this, but the Bristol Stool Form Scale, which kind of gives you descriptive terms of what stool should and should not look like. Type 1 and 2 are generally associated with constipation. Type 5 and 6 and 7 are generally associated with diarrhea. In between the 3, 4, and 5 are variations of quote unquote normal. But as you can tell, there's going to be a person who all their life has been type 3 stool. And if they move from type 3 to type 5, that's a significant change. And so it takes a lot of interpretation for what the patient's norm is too. You can't just use this as a solitary guiding factor. So within that, and using that Bristol stool scale, you can create subtypes of IBS. An IBS with a constipation predominance, which would be that type 1 to 2 stool. IBS with diarrhea predominance, which is type 6 to 7 stool. Those that are mixed. What does it mean where you have both constipation and diarrhea? The actual criteria would say that more than a quarter of the time they'll be with one or the other. So more than a quarter of their stools will be that constipated stool, more than a quarter will be that diarrheal stool. Then there's the unclassified, where they don't really have the bowel changes, but they have IBS-like symptoms. And then there is this offshoot of this post-infectious irritable bowel syndrome, which we'll talk about a little later. So how do you diagnose this? As I mentioned, there is no solitary test. Really the most important thing is history and physical. And really the most important part of it is that it should be normal. If there's an abnormality on the physical exam or the history, that should prompt us to think of something else. Remember, irritable bowel syndrome is really the diagnosis of exclusion. When everything else is normal, then you think of irritable bowel syndrome. There is some lab testing we do, and again, it's looking to see other factors. For instance, we check to see if the person's anemic, has low blood counts. We look to see if they have blood or inflammatory markers in their stools. We look to see if they have any changes in their liver enzymes. We make sure they don't have something like H. pylori, Helicobacter pylori, a very common infection we get in the stomach that can cause a wide array of GI symptoms. Beyond that, people always ask, do you need a colonoscopy or endoscopy or CAT scan or whatnot? Actually, you don't really need that to make the diagnosis, as long as the history and laboratory testing are normal. But we do sometimes decide to do further testing if you have any of these alarm symptoms, particularly the age and onset over 50. That should always trigger more workup. Rectal bleeding, diarrhea that awakens a person from sleep. That's almost always considered pathologic. Weight loss, or even a family history of inflammatory bowel disease, that's the IBD, or colon cancer. One thing I wanted to pause and talk about, in my practice, I've seen many times, is patients come in with telling me that they have been told they have irritable bowel syndrome with constipation predominance, and that they've been using all these laxatives and they're just not getting better. That right there is a big red flag that they really don't have irritable bowel syndrome, but they have something called Synergic Defecation. What that really means is that the pelvic floor musculatures are not coordinating the act of having a bowel movement the way it's supposed to occur. So I've got this diagram here that I think can be sometimes helpful. So in the normal person's bowel function, when they're going to have a bowel movement, this external anal sphincter will relax. And when it relaxes, this puborectalis muscle, which is slung around the colon, will actually also relax, allowing for a straighter line for stool to leave. That's normal. In dyssynergic defecation, what happens is the external anal sphincter does not relax. And the puborectalis, instead of going this way, actually accentuates and pulls closer, making a sharper angle for stool to come through. And then that person can't get the stool out. What I have found is very helpful in distinguishing that is a patient will say, I feel like I'm pushing and pushing against a wall and only a little bit comes out. I can never really get it out. that's a person that really needs to be treated completely different than irritable bowel syndrome. And they have great techniques of trying to help them go from this spot back to this spot, the normal bowel movements, and they feel better. So now that we know what irritable bowel syndrome is and the different types of it, us in medicine, we always want to know what's the cause, right? If you know the cause, you can then treat the outcome, right? And make it better. So unfortunately, which is very frustrating for me as a physician, nobody really knows. We have made a lot of postulates. So if you go back 20 years ago, we would say irritable bowel syndrome is a combination of poor gut motility and a hyper sensitivity of the nervous system of the gut. More recently, as we've expanded our knowledge, we talk about now just inflammation of the gut, that your patients with irritable bowel syndrome seem to have more inflammation in their gut and maybe have an inflammatory process there, that there's a problem with the fecal flora, including things like bacterial overgrowth, which has been a real hot topic in irritable bowel syndrome and in GI in general. Food sensitivities, which just about every patient I see now talks about what foods are they sensitive to, what foods could be triggering it. And there does appear to be a genetic basis in irritable bowel syndrome, and we'll talk about that in a little bit. So I'm going to just lower this down. I just want to see, does anybody have any questions now? We can take a moment to answer any questions that are there. I think they'll work out. I'm going to stop streaming this. Yeah. Does anybody have any questions so far? Can everybody hear me okay?
I think we'll wait till the questions
I
afterwards.
just want to make sure everyone can hear me.
Yeah. I have some questions, but I'll hold on.
All right, fair enough.
Thank you.
All right. Share the screen. All right. So back to the topic. I think you should be able to see the talk again. All right. So we're talking about so the first step, the gastrointestinal motility. Most patients with irritable bowel syndromes, if you study to see how long it takes to get from point A, the mouth, to point B, the rectum, they will have alterations in them. Patients with constipation predominance will have longer transit time of their colon, while patients with diarrhea predominance, when they eat, we notice faster motility through the gut than quote unquote in non-irritable bowel syndrome comparable patients. And to take that a step further, when you give a patient with irritable bowel syndrome medications that can augment or decline gut motor function based on their symptom, you will actually see them improve their symptoms. So there's clearly a component of this which is related to gut motility. Hypersensitivity. This is actually a part that I like more. I think it's much more common than we like to think about, is the nervous system to the gut of a patient with irritable bowel syndrome is more attuned to what's going on in the gut than the average individual's is. And they've done some really kind of, if you think about how they did this study, how they got patients to agree to this study, it's amazing. They've taken patients with irritable bowel syndrome compared to normal individuals. They've taken these big balloons and they put the balloons in all parts of their GI tract, the small bowel, the stomach, the esophagus, the colon, and they distend the balloon with a set amount of gas and pressure. And they found that when you take the same amount of distension in the normal individual and in the patient with irritable bowel syndrome, the irritable bowel syndrome will respond to that distension far greater than the normal individual. So it's the same distension, same amount of pressure, same amount of force, the irritable bowel syndrome will respond to it more. Subsequently, then they took a patient with irritable bowel syndrome who complains of bloating. And they actually studied how much gas is in that person. And if they compare that to somebody post a meal who has the same amount of gas, the irritable bowel syndrome patient will complain of bloating, while the person who doesn't have it with the same amount of gas will not complain of bloating. So there's, again, the nervous system is responding to a stimuli more intensely than a person who doesn't have this disease. it's not sure if that system is attributable to the enteric nervous system, which is the nervous system of our stomach. And actually, it's pretty intense. There's more neurons there than there are in the brain, or if it's coming from the brain, centrally acting. But recognizing that there's got to be some interplay between the brain and the enteric nervous system has led to this term that we use now called the brain-gut axis, which many of you may have heard of. And it's actually been really helpful in trying to just devise better treatments. When you try to look at it as that there is some type of communication brain to gut, you target those pathways, you actually lead to improvement in symptoms. Inflammation in the gut. This was never really thought of. We've always thought of irritable bowel syndrome as being the absence of gut inflammation, yet symptoms, but that's not true. There clearly has been studies to demonstrate in an irritable bowel syndrome patient, there is increased lymphocytes in the small bowel and colon. These lymphocytes release multiple different inflammatory, multiple different factors that lead to an inflammatory response. Of them, nitric oxide, histamine, and proteases are most commonly seen. It's not really important which ones predominate. It's just that patients with irritable bowel syndrome do seem to respond with some degree of increased inflammation in their gut. And in trying to target those cells, those lymphocytes or mast cells, which release a lot of cytokines via a histamine response, you do decrease the symptomatology of irritable bowel syndrome. Something that I thought was very unique is, and it goes back to how our current society is trying to change our thought process on antibiotics, is it is very easy for someone to get a GI illness, whether it be something bacterial like salmonella or a parasitic infection, or even a viral gastroenteritis. And maybe some of you in the audience have had this happen where you recover, your acute symptoms are better, but you're not the way you were before. Your GI tract isn't functioning right. This is called a post-infectious irritable bowel syndrome. And we don't know exactly why it happens, but we think a lot of it has to do with some degree of malabsorption, meaning the gut has been injured from the infection, and in the injury, it just hasn't recovered its normal function yet. Or perhaps even the antibiotic use. You know, you took a course of an antibiotics, you took a Z-Pack because you had some diarrhea, maybe you needed it or didn't, and the Z-Pack, or the antibiotic, hurts the GI tract in a way that we're just now starting to understand, and has led you kind of with abnormal function. One of those pathways seems to be there's an increase in serotonin. Serotonin is a good word to remember when it comes to the GI tract, because the manipulation of serotonin seems to play a big role with GI symptoms and irritable bowel syndrome. So, and a hot topic is the microbiome. Sure, everyone's heard it in some way or the other, either through probiotics or what they're talking about, and just all these disease states that are clearly linked to the gut's bacterial makeup. There is no doubt in an IBS patient, they have different gut flora than in an age-matched normal individual. In a kind of a crazy, cool study they did, they have these germ-free animals that have no GI symptoms. You take stool from an IBS patient, you deliver it to the germ-free animal, essentially giving them the bacterial biome of the IBS patient, and you will induce the IBS symptoms in that animal. So there's clearly a bacterial hypothesis. Unfortunately, the next step would be, well, geez, if I can change the bacterial makeup in this IBS patient, shouldn't I then make them better? And there is some data about probiotics doing this, particularly in diarrheal predominant irritable bowel syndrome. However, it is not borne out in further studies. And I feel like sometimes people say I'm saying something really inappropriate when I say this, but the use of probiotics in irritable bowel syndrome has not been shown to be beneficial. In fact, there is some data that it may be harmful. I think this is something that one day we will unlock the secret, and we will really make a person feel better using their microbiome to our advantage, but we are not there yet. We'll talk about that a little bit more later on. Bacterial overgrowth, or small intestinal bacterial overgrowth, another pretty hot topic, a thing that easily develops in a GI patient. It's important to know that this is a second separate disease entity and should be treated as such. So if you qualify for irritable bowel syndrome and you think, well, maybe a part of it is I have SIBO for short, small intestinal bacterial overgrowth, and you treat for that, the data supports that you will not make the irritable bowel syndrome better. If you do get better after it, which is great, we always want patients to be better, it most likely means you did not have irritable bowel syndrome, you had SIBO. Food sensitivity. This is probably, after the microbiome, the second most common thing a patient wants to talk about, and rightfully so, is what food should I eat or shouldn't I eat to help me with my symptoms? Almost every patient with irritable bowel syndrome will tell you that there's a trigger. Just a few days ago, I had a patient tell me that it was grapes, and grapes is a possible trigger for irritable bowel syndrome. Anything can be a trigger with it, but exactly what one particular item has not been met with great success. We center most of our studies on food-specific antibodies to see if that could be helpful in eliminating those foods we have antibodies against, carbohydrate malabsorption, and gluten sensitivity, all things I'm sure we've heard about, even just if you watch the TV to do. So one important thing, a lot of people like to do skin prick testing for food allergies. That has really been inaccurate and is unvalidated. In fact, the GI societies do not recommend utilizing skin prick testing for food allergies as a way to guide one's diet. Many studies have shown that it just doesn't bear out. However, food allergy testing while checking immunoglobulin levels or IgG levels, which is a blood test to test for it, probably has more promise, and you can use that data, but it still is unvalidated. There is a study to show that if you take items, let's say the classic one is beef, and you test high on antibodies against beef, and you take that and you've taken everything else away, you give that patient beef, you won't stimulate the symptoms. So is it really causing the problem or not has not been validated, but I do think there's promise, and I think we're getting closer to figuring out the right way to determine specific food allergies that are causing problems. Gluten is big, there's no doubt. Now, obviously, the gluten-free world has dramatically changed in the last 5, 10, 15 years. There is a considerable amount of overlap with celiac disease and irritable bowel syndrome, and I do think every patient who you're contemplating irritable bowel syndrome for should be, with at least a blood test, ruled out for celiac disease. There is no doubt in most patients with irritable bowel syndrome, if you do take them to a gluten-free diet, you do improve their gut function. You do seem to affect their motility, and their bowel frequency seems to improve. Does that mean that they had celiac disease? No, but there just seems to be a crossover between the two. Carbohydrate malabsorption. I wanted to give this its own slide because I think this was a big breakthrough in irritable bowel syndrome when it first was released about 15 years ago. There's something called fermentable oligo monosaccharides and polyols. We call them FODMAPs for short. They are basically complex carbohydrates get fermented in the gut. And what the premise was, in patients with inflammatory bowel disease, a much more severe and yet a very different disease entity, they found that this fermented process of these carbohydrates are difficult to digest. And if you remove them, those patients actually do better. And they actually score better on their inflammation scores as well. And so then this was extrapolated from this with a patient with irritable bowel syndrome. As you remember, we did mention there is an inflammatory component to this disease process. If you give them this diet, could you also improve their symptoms? Oh, I'm so sorry. More than that. All right, sorry about that. If you do that, will you improve their symptoms? And the answer is probably yes. Most patients who can really strictly adhere to what's called a low FODMAP diet, will have symptom improvement. In those that don't, you usually will take it a step further to a low carbohydrate diet where you go to less than 20 grams of carbohydrate in a given day, or you can try a low fructose diet. Fructose in its digestion leads to a lot of gas formation, and patients do feel better. To give you a blanket recommendation that, oh yes, all irritable bowel syndrome should have a low FODMAP diet, we definitely need more studies, but I think for the right patient, it makes a big difference. Genetics. There is clearly studies that have shown, both in twin studies and in familial studies, that there is a preponderance, there is a genetic preponderance of irritable bowel syndromes within families. No specific gene has been identified yet, so therefore no target therapy has come out, but it is there. And it's not surprising when you see a patient say, oh yeah, my mother used to suffer from symptoms and now I do too. Or I had a twin that suffers. There is a genetic predisposition, and it's something that I think hopefully as we get better with genetic testing and our understanding of how to manipulate it will become a treatment option. And the last thing that I think most of GI doctors, or at least maybe it's easy to skip over the psychosocial part of our medicine and the delivery of medicine. That's such an important aspect of it. Many patients with irritable bowel syndrome will have stressful lives, and a lot of people have stressful lives, but they'll feel that stress a lot. They report more lifetime daily stressful events. They suffer from anxiety. They have trouble with sleep. All of these are risk factors for irritable bowel syndrome. And as I mentioned earlier, if you don't address that, that will negatively affect their GI symptoms. So it's just as important as treating their irritable bowel syndrome as to treat them for their psychosocial issues as well. And it's also very important that we take a look to see if there's any underlying abuse history, because treating that head on will really improve irritable bowel syndrome as well. So we just summarize a whole bunch of different factors that play a role to develop irritable bowel syndrome. And this is a kind of a graph that kind of shows you all of those things. So we talk about genetic predisposition, underlying prior infections, the inflammation part of things, where I mentioned that serotonin and mast cells, there, the hypersensitivity, the gut function of it, the microbiome, the motility, the psychological factors, all of those combine to really make this one disease entity, irritable bowel syndrome. So how do you treat this? Now we've learned how to diagnose it. We've learned what are the different ideas of how it develops. Now, how are you going to make a patient better? It's customized to each patient. As I mentioned before, you can have two patients with the same disease present with different symptoms, and they'll need different treatments. And it's about taking the time to figure that out. It is usually going to be a combination of diet, lifestyle, and medications. So let's start about the dietary and lifestyle modifications first. So we talked about that low FODMAP diet. I think it can be helpful. And I actually often ask my patients to really try to keep a food log, because you will find something sometimes that really just wouldn't have ever come up in conversation if it wasn't the log. And I always give patients an example of a patient I had probably about 10 years ago, terrible symptoms. Finally, she kept the food log, and she was buying this one brand of Tropicana lemonade, and she was having that almost daily. And we took out that lemonade. I can't even say what was in the lemonade to cause it. And bang, her symptoms went away. I suspect it was the sugar, the carbohydrate in it, but her symptoms went away. And it was as simple as just this lemonade she drank. You want to exclude gas-producing foods, and those include things like beans, prunes, all of those things that we kind of know about. Gas, again, leads to distension, leads to pressure. And remember, in irritable bowel syndrome, patient has that hypersensitivity, they will sense it more. So you want to reduce that. You want to avoid lactose. And in fact, it's probably one of the first recommendations almost every GI tells patient. Why? Because lactose has two aspects of it. One, many of us are deficient in the production of lactase, the enzyme to break it down. And so the people will say, well, then I just have lactose-free milk. And you probably could, but there's also something to be said about cow's milk in general, that it seems to drive an inflammatory response. And as I mentioned, irritable bowel syndrome has to do with inflammation as well as those other factors. And so by removing that dairy, you often will decrease inflammation in the gut, will often improve symptomatology. We talked about gluten and the interplay of irritable bowel syndrome, celiac disease, and gluten sensitivity. So you do remove gluten. The low FODMAP diet, which I really like, and fiber. Fiber is helpful not only for patients who have constipation, which I think we traditionally think about it, but it's actually helpful for diarrheal patients as well. Fiber is just a bulking agent. So you bulk the stools, makes it easier to pass. And if it's too loose, you bulk the stools, lets you hold it a little bit better. So fiber works in both cases. Patients always ask me, does it matter insoluble versus soluble? And a lot of people, nutritionists, love to talk about which one to do most. In fact, the studies have actually shown it doesn't make a big difference to an IBS patient. And a constipation patient in my diarrhea patient might do not have IBS. But in an IBS patient, it doesn't seem to make a big difference in soluble versus soluble. So I tell patients, see what it is, see how you like it, how you respond, and go from there. Physical activity is super important. Most IBS patients are more sedentary than their counterparts. Not everybody, but most are. And if you can hit that magic 20 to 30 minutes of brisk physical activity a day, gut function improves. Whether it's because you release endorphins, which improves your neurologic function of the gut, you stimulate gut function or motility, you decrease inflammation. Physical activity does seem to improve IBS scores across the board. Medication management, which I think is where a lot of people end up on. So we break that down between the two groups: constipation predominant, diarrhea predominant patients. So for the constipation predominant, we mentioned fiber. That is probably the first line of it. For those who fail the GI world, we like Miralax. It's cheap, very effective, and almost no side effect profile. It is considered superior, I'd say, to any other of the over-the-counter laxatives in its side effect profile, including things like lactulose or Dopalax or Seneca. And one pet peeve of mine, people really love smooth move tea. That is just Seneca, just repackaged into something that sounds different. It's just Seneca. If those fail, then we move on to medications. And again, the medications are trying to address those issues we talked about in irritable bowel syndrome. For instance, Amitiza works on increasing the fluid makeup of stool, giving more water in the stool, easier to pass. Then the Linzess and Trulance work at trying to correct the permeability of the mucosal wall, thereby increasing stool frequency with that. Zelnorm and Ibsrela, which I've never prescribed, it's not very easy to get in the United States, but Zelnorm or its newer drug Motegrity work on that motor part of the gut, improving gut function through that serotonin pathway to improve its the motility of the gut, moving the bowels quicker. Some combination of above is generally what we utilize there. For the diarrhea predominant, you can use antidiarrheal agents, and loperamide is the only one, the over-the-counter agents that have been studied. And it does seem to help. Many patients will notice marked improvement. There are two prescription drugs, Lotranex and Viberzi. Lotranex is only for women with severe symptoms over the period of 3 months. It requires a lot of FDA approval. You have to be enrolled in a special prescribing program. I personally am not enrolled, and I have not had the need for it in my practice. And I think most patients can get control without it. Viberzi was the newest kit on the market when this came out for diarrhea predominance. It's a fine drug, but it has, for someone like myself who also goes to the hospitals quite a bit, it has a lot of side effects, particularly what it does to the gallbladder, pancreas, and bile ducts. I think you have to be really careful that you've had a talk with your doc about, am I a right candidate to take this drug or not before you take it. I actually would prefer, if loperamide doesn't work, to utilize what's called bile acid sequestrants. They are basically drugs that come in either powder or tablet that binds bile in our gut. And by binding the bile in our gut, we actually can induce a decrease in bowel frequency. And it's generally well tolerated and it generally works. So what about the middle part? We talked about irritable bowel syndrome. The first hallmark feature is abdominal pain. And so far, I've only been talking about the constipation and diarrhea part of things. The pain is actually very important, and you can't forget that. The first thing that almost every patient with irritable bowel syndrome should have available to them is an antispasmodic. As we talked about, motility and visceral and sensitivity plays a big role in the symptoms. So an antispasmodic relaxes the gut and improves its motility. The two that we commonly use are hyoscyamine and dicyclamine. Their trade names are Levsin or Bentyl. I personally like Bentyl more. I think it's easier to dose than hyoscyamine. They both work fine. I think that every patient should have it available should that help. The next line, which I think for again the right patient works very well, is the use of an antidepressant. It's not that you're trying to treat their mood. It's not that you're calling them crazy, which is, I think some patients get the feeling when you say, hey, I want to start trying an antidepressant. It's going back to what we talked about with mechanism, right? We talked about how this is a system where the nervous system is hyperacute, and that serotonin arm, the gut motility is altered there, whether it be from inflammation or whatever it be. So the use of an antidepressant can really regulate that part of things and kind of restore the function of the nervous system back to a normal individuals. And patients with irritable bowel syndrome get dramatic patient symptom improvement when utilized right. In general, we use something called a tricyclic antidepressants, or if you've heard of these words like Elavil or amitriptyline. Those are the ones we like. They work very well in patients with a diarrhea predominance. If you do have coexisting things like depression, then we usually use like the SSRI or the Prozacs of the world, and they work pretty well as well. So people always ask about antibiotics. So this goes back to when we talked about that SIBO or bacterial overgrowth. Antibiotics, I think, do have a role in irritable bowel syndrome, only in those patients with bloating who do not have constipation. There is some improvement with the 2-week course of an antibiotic with them. It will usually be short-lived, meaning that it'll recur within probably in a period of about 2 to 3 months, but they will have improvement for those 2 to 3 months if they failed other therapies prior. Finally, like probiotics that we talked about before, there is no recommendation for the use of probiotics in irritable bowel syndrome. I'm not saying you can't try it. It's harmless. You can try it. If you feel better, great. But there is no company line recommendation that I can use. So what if all of that has failed? All of that's failed. We do talk about then going the next step and getting behavioral modification with the help of our psychologists and psychiatrists about trying to work that brain gut axis even further, see what we can improve from there. You talk about the use of anxiolytics, but it's a slippery slope that I caution most patients against doing. You get heavier duty about, oh, well, what can I do to stop the gut inflammation? And there are a couple of drugs that are utilized to stabilize those lymphocytes and the mast cells that are producing some of the gut inflammation. And then the idea of fecal transplant. I mentioned how the germ-free animal, if you take stool from an IBS patient, you can induce the symptoms. So the question is the reverse end. If I take the microbiome of a normal person and deliver it to an IBS patient, can I cure them of their IBS? And initially, it looked like, yes, this is going to work. Patients really had great response. And at 3 months, the patients who underwent a fecal transplant really tell us, they sing the praises of it. But by 12 months, almost all of those patients recur their symptoms. So it's still investigation. It's still something we need to learn more about. All right. That's what they told me to do, about 30 minutes. I hope that was about right.
That was perfect. Thank you. We have a question from Mr. Alan Wang. Could you please list the items in the low FODMAP diet?
Sure. I think that's a great question. It's an extensive list, right? Because it covers everything from high fructose corn syrup to soy-based products, gluten-based products, dairy-based products, and fruits, including, it's controversial to say, but the avocado is considered a high FODMAP diet. It's not that it's unhealthy. It's not that it's I would actually refer you to a web page if I can, where you can get a much more comprehensive list than I can list. Should I put it in the chat, the web page? I'll just type it in the chat.
That'd be great. Thank you.
So if you go to this website, ibsdiets.org, it'll be, I think, the third selection on the panel that says low FODMAP, and you click on it, you'll get a very extensive list of low FODMAP.
Great. And then I see someone's hand up, but I just would ask if you could put your question or comment in the Q&A box. That would be great. I have a question for you. To a family member of mine, it says that they have IBS. Okay, fine. And they have trouble eating cheese, but they have no trouble drinking milk or eating, using butter or anything. Is that a true IBS diagnosis? Like, do they truly have IBS, or is it something that maybe they got, maybe they did, but now they don't have it anymore? So I just wanted to get your thoughts.
That's a great question, and I think that's a very common thing. I think that I don't know if that would constitute IBS having trouble with one particular food item, right? Remember, we talked about IBS is you have pain and you have symptoms that are present commonly and they present over a period of time. It sounds like this person definitely has a food sensitivity, and cheese is different than dairy, right? You've changed the structure of the proteins in the dairy product to make cheese. Especially hard cheeses are different than soft cheeses, and many patients don't tolerate certain cheeses while they do everything else fine. I think he or she has a food sensitivity. Right? And I would treat it like that.
Okay, thank you. I'll let them know. I appreciate that. Does anyone have any other questions that they want to put in the, they don't see the link for the FODMAP diet in the chat. Oh, it's in the chat.
I think I see it.
I'll send it. I'll send it.
Oh, you know what? I sent it somehow. I know what I did. I did it wrong. I'll do it again.
Oh, that's not it. While we're doing that, do you see it, Mr. Wang? Okay. Okay, so Miss Susan Brown has a question. If a side effect is weight loss, do you have a particular recommendations of foods to help with regaining weight without non-recommended foods?
Yeah, that's a great question. So I think what you're saying is that if because of the irritable bowel syndrome, I'm losing weight, what can I do to gain the weight back? Which is a great question. First, I would always suggest that weight loss is an alarm symptom, and make sure you've had that checked out with your doc, that there's nothing else going on that causes the weight loss. But you look at that low FODMAP list, right? The low FODMAP diet doesn't stop you from having things that have enough fat in it, enough substance in it to gain the weight back. It's just about going through the list of foods that you can and can't eat, optimizing that for what you can do. And I find sometimes the best ones is to really stick with the protein-based stuff, right? Like, actually, the low FODMAP diet doesn't at all affect protein. And protein seems to be well tolerated. It's just the way we manipulate the protein. So just a cleaner cook on the protein, no sauces, no processing of it. And most patients are able to gain their weight back pretty quickly.
Okay, great. Does anyone else have any other questions for Dr. Gupta? I have one more. I feel like I hear on the news and what I read about inflammation and foods to avoid. And so how do I ask this? So there are foods to avoid just for like general health, right? To avoid inflammation. But is there something like a diet that we all should, just for healthy gut health rather, that we should kind of be maintaining? Should we all be drinking kombucha?
Yeah, so that's a great
Should we all be
question.
eating yogurt? What should we be doing? Like a general question.
I don't think that, because everyone's different. I don't think there's one thing that everybody's going to benefit from having. Me as an Indian, I would say turmeric is that thing. That a good healthy dose of turmeric. And the reason why turmeric is just so if everybody's, it's called curcumin in the United States for the marketed version. Turmeric is a great anti-inflammatory. It really seems to reduce gut inflammation and whole body inflammation, but it is not for everybody. But I do think it's a nice little, better than a multivitamin in my mind. But what you're asking, I think that's where there's been a lot of talk about two different diets in particular. One is the anti-inflammatory diet, which I don't prescribe to, partly because the anti-inflammatory diet is kind of like a little bit of a money-making diet. I'm always hesitant of diets that aren't right out there for you to have, right? And then number two is the Mediterranean diet. And actually the Mediterranean diet has shown across the board improvement of dementia, blood pressure, cardiovascular profiles, everything, and including the GI tract. Patients with irritable bowel syndrome do get an improvement with the Mediterranean diet. Just for those in the audience who don't know what that is, a Mediterranean diet is basically the removal of all processed foods from one's diet. Strictly starts eliminating meats like I think red meat's once a month, fish is like once or twice a week, chicken is like once or twice a month, pork and all is kind of out as well. And it's just a very natural diet. And you know, there might be a reason why the people in the Greek islands live longer than everyone else, right? I'm sure it's more than just diet. It is true.
Yeah, I think it's also it's just living on an island, maybe. I don't know.
I think there's no doubt about it.
Yeah. Okay. Well, thank you. I obviously maintain a Mediterranean diet, being Greek, but I just wanted to just see if I need also incorporate some kombucha. But Indian and Greek food is definitely two of the cuisines that are very healthy, especially with limiting meat intake. Okay. Well, with that said, if there are any other questions, please. Are there any questions? Oh, see, now the floodgates open. Miss Susan Brown, asks, what about protein powders as supplements? Is dairy yogurt not recommended?
So I love your question, Ms. Brown, about yogurt. You know, I think yogurt is one of those, the one exemption I always make, depending on each particular patient. So it's like it's a trial basis thing where I think most patients will tolerate yogurt well, but remember, yogurt in the United States is not yogurt elsewhere in the world, right? Yogurt in the United States that you buy over the counter is heavily manipulated and heavily processed. It stays good for much longer than it ever should, even if you buy ones that say probiotics. So the goal is to try to get as natural of yogurt as you can get. I think most patients tolerate that very well and get an excellent source of protein with an excellent improvement. So I do ask my patients to try yogurt as a protein source. If they notice their symptoms worsen with it, then they should stop. I think that would be it. I am not a fan of protein shakes or powders otherwise. However, Ensure Clear, that's a reasonable protein shake. It's tolerated by most IBS patients pretty well. So it's an option out there. Again, you know, the whole goal is we want to stay away from things that are processed, right? And all of these protein shakes and powders, and I'm not trying to be negative about it, but they are, in essence, processed food, right? So I would try to stay.
Okay. David says, I've been told that fiber will contribute to abdominal pains due to slow motility and the buildup of fire in the colon. How to balance fiber with pain? How much fiber should one with IBS aim for? Can a supplement be taken along with Miralax? Those are three questions. Those are three good questions.
But those are really good questions. And I think it is important to make that, I'm glad you brought up, David, is that you're right. If you start, let's say you're constipated and you start just, I'm going to address this as fiber, and then you notice that it's not working for you, meaning that constipation isn't relieved, you will have worsening pains, because it's not that it causes slow motility. It's fiber is gas producing, right? And if it produces gas and gas builds up, you will feel more pain, right? So you want to get the bowels moving first and then incorporate fiber. It's actually the hallmark of something we used to call bowel retraining in a constipated patient, is that you start them with Miralax. And once you're moving your bowels, I would say reasonably regular, 1 or maybe 2 times a day, and bowel movement feels like you're getting a complete bowel movement, then you slowly start to integrate fiber. And you can go up from 1 dose a day to 2, 3 times a day as you are continuing to move your bowels. And once you're in that right spot where things are moving, you can come off from Miralax at the time. There's nothing to say you can't continue a combination of both. It's about trial and error, playing with it till you get to the right level. Is there a necessity where you must take fiber? No. There's going to be a patient out there who, anytime they try fiber, they have symptoms. And certainly, Lord knows, there's a large consensus or a large group of physicians out there who really feel that we should be low fiber individuals, not a high fiber individual. It's just about playing with what's right for you. I hope that answered their question.
I think it did. Let's see here. Move right along to L Pitt. If IBS type symptoms are irregular, for example, not once weekly over 3-month time frame, might it not be IBS? My occurrences could be frequently for a week or two, then not at all in the next 2 weeks. Oh dear.
So I think that absolutely could still be IBS. As I mentioned, there's no one diagnostic test for sure. And while we use this criteria, that doesn't mean that everyone is going to fall perfectly into it. It just depends. But I would say, again, it's always good to make sure you're not dealing with something else. And it's something where it comes for a couple of weeks, then you're perfectly normal, then comes for a couple of weeks. I suspect there is a trigger, and it's about looking to see if the trigger is there. Of course, you would still treat for the symptoms. You'd still be as proactive as you can so that when those symptoms are starting to arise, you can intervene and try to help and feel better. But looking back, whether it's food log, looking at what's going on emotionally, socially, outside of everything, there's usually a trigger.
Great, thank you. Dr. Gupta, do you want to also perhaps maybe share your office number if someone would like to make an appointment with you as well into the chat?
Should I just send it in the chat?
Yes, please. If anyone wants to make an appointment, where's your office located these days?
Old Georgetown Road.
Oh yeah, I'm familiar. Right by the hospital.
Right down
the street. Okay. Well, if there are no other questions, thank you so much. If there are no other questions for our speaker this afternoon, we'll end here. Thank you again, Dr. Gupta. I know today was a very busy day with your patient load, but greatly appreciate your time.
Anytime. Thanks so much for having me, guys, and I hope you all have a good day.
Bye, everyone.